peripheral vascular disease. Arterial/venous, acute/chronic. Peripheral vascular disease. A term used to describe a group of diseases that involve pathophysiological changes in the peripheral arteries, i.e., excluding the coronary arteries, or veins resulting in blood flow disturbances. Lymphatic disorders, also considered a form of PVD. Lymphatic system, ducts and nodes. Plays a role in filtering foreign particles. Provides the only means by which interstitial proteins can return to the venous system. If blocked, obstructed, or removed, edema may develop with risk of infection. Raynaud's disease. Characterized by bilateral intermittent arteriolar vasoconstriction/vasospasm in the hands and feet, often precipitated by emotional factors, cold, tobacco, causing color, white to blue to red, and temperature changes as well as burning pain in affected digits. Is usually associated with underlying systemic disease, for example, autoimmune disorders. Unlike other acute arterial disorders, Raynaud's is, with proper management, for example, avoidance of triggers, essentially benign and self-limiting. Management. Thought to be vasospasm resulting from an exaggerated response to SNS stimulation. Calcium channel blockers, i.e. nifedipine, Adalat, diltiazem cardizem, may be used. Prevention. Avoid/manage stress. Avoid exposure to cold/cold H20. Avoid nicotine, caffeine, drugs that elicit a vasoconstrictive effect. Safety precautions, acute arterial insufficiency, acute arterial occlusion. Usually involves complete blockage, is of sudden onset, and constitutes an emergency situation, muscle necrosis within 2 to 3 hours. Etiologies include arterial compression, thrombosis/embolism, arterial injury/damage. Risk factors. Non-modifiable, modifiable. Risk factors. Age. Gender, male. Family history. Modifiable risk factors. Hypertension, diabetes, hyperlipidemia, smoking, obesity. Thrombosis, the formation of a blood clot within a blood vessel. Can occur in the arterial or venous systems. Leads to obstruction of a blood vessel in the circulatory system. Can lead to ischemia and infarction, and even death. Can also lead to embolism. Clot within a vessel breaks free and travels through body, embolizes. Thromboembolism is combination of a thrombosis and embolus. Why does this happen? Hemostasis. Formation of blood clot formation at the site of vessel injury. Carefully regulated system. Involves platelets and coagulation factors. Lack of coagulation factors, bleeding. Overactive coagulation cascade thrombosis. Arterial thrombosis. EA. Ischemic limb. What are the features of an acute ischemic limb? Fixed mottling and cyanosis. Remember the 6 P's. Pain, pallor, pulselessness, perishing cold, poikilothermia, paresthesias, paralysis, excruciating pain, color pale or cyanotic, maybe pulseless, skin cool to touch, loss of sensation/position sense, loss of movement, chronic arterial insufficiency, peripheral arterial disease, primarily caused by atherosclerosis, disrupting the balance between arterial oxygen supply and demand. Risk factors same as for CAD, with diabetes, HDN, and smoking as particularly high risk factors. See Table 40-3. Collaborative care, peripheral arterial disease. Peripheral arterial disease. Thickening of artery walls. Progressive narrowing of the arteries of the upper and lower extremities, resulting in tissue perfusion and ischemia in the area distal to the obstruction. May be acute or chronic. Risk factors: typical patient, smoker, 2.53x, Diabetic, 3-4x. Hypertension. HX of hypercholesterolemia/AF/IHD/CVA. Patients at risk. Based in part upon the above observations, the 2005 American College of Cardiology/American Heart Association, ACC/AHA, guidelines on PAD, which were produced in collaboration with major vascular medicine, vascular surgery, and interventional radiology societies, identified the following groups at risk for lower extremity PAD. Risk factors. Atherosclerosis, same as RFs for CAD and CVD. Smoking, 2.53x. Diabetes, 3-4x. Hypertension, increased age greater than 50, male and family history. Rare, homocystinuria. Peripheral arterial disease. One limb is usually affected more than the other, therefore always compare bilaterally. Lower limbs more susceptible than the upper limbs. Most common locations for stenosis are the aortoiliac bifurcation and the femoral bifurcation. Nearly half of the clients with arterial PVD have associated CAD. Clinical manifestations. Intermittent claudication, pain in calf, thigh, or buttock depending on the location of the blockage. Rest pain in forefoot especially at night, advanced disease. Capillary refill. Elevational pallor. Dependent rubor. Pins and needles sensation, paresthesia, due to ischemia. Affected limb cool to touch. Peripheral arterial disease. Weakened or diminished pulses. Chronic trophic changes. Thin, shiny, dry or scaling skin with hair loss. Thick, yellow, and brittle toenails. Muscle atrophy. Ulceration, arterial, gangrene possible. Brute. Erectile dysfunction, for example, aortoiliac disease. Please note the differing characteristics of arterial and venous ulceration in course text, Table 42. Pictures. Ulcer. Associated with claudication plus signs of ischemia. Occur on dorsum of foot plus anterior skin. Pulses, cold to touch, hairless skin. Painful, punched out edge. Diagnosis, history, symptoms and presence of risk factors. Physical exam, signs. Doppler assessment of peripheral pulses. Ankle/brachial index, ABI, normal is 1. CP, 1015. Treadmill, exercise testing. Angiography, necessary before any surgery. ABI clinical correlation. Greater than 0.9. Normal limb. 0.5 to 0.9. Intermittent claudication. Less than 0.4. Rest pain. Less than 0.15. Gangrene, BP higher in ankle than arm. What does the ABI mean? Take the highest measurement in both limbs. Low ABI is also predictive of an increased risk of all-cause and cardiovascular mortality and of the development of coronary artery calcification. 95% sensitive in detecting angiogram-positive disease and around 99% specific in identifying supposedly healthy subjects. Goals of management: reduce progression of the disease. Promote arterial blood flow. Promote vasodilation. Prevent vascular compression. Pain relief. Attain/maintain tissue integrity. Promote adherence. Management: risk reduction/reduce disease progression, smoking cessation. Weight reduction. Exercise, for example, walking, unless contraindicated. Reduction of blood lipid levels. Diet, for example, cholesterol, saturated fats and TFAs, fiber, and, in some cases, pharmacologic intervention, for example, Antilipidemic drugs. Blood glucose and blood pressure control. Antiplatelet meds. Promote arterial blood flow. Keep lower extremities below the level of the heart, for example, reverse Trendelenburg position. Encourage, or assist with, walking or graded isometric exercise to increase collateral circulation, if not contraindicated. Avoid prolonged standing or sitting in one position. Pharmacologic therapy. Inhibit platelet aggregation, promote vasodilation and prevent vascular compression. Apply external warmth, for example, socks, warm bath, or warm drink, promoting tissue perfusion. Never apply direct heat as it may cause a burn. Prevent exposure to cold and chilling. Avoid crossing legs/constrictive clothing and accessories. Smoking cessation. Minimize stressful situations. Maintain tissue integrity. Pain relief. Analgesics, opioids. Maintain tissue integrity. Prevent infection/injury/trauma. Meticulous food care. Well-balanced diet that includes adequate protein. Attain and maintain ideal weight. Promote self-care. Patient/client education. Surgical/radiological management. Management depends on the etiology and may include embolectomy, revascularization, anticoagulation, fibrinolytic agents, amputation. Prevention best. Know those at risk and monitor them closely. Percutaneous transluminal angioplasty, PTA, with stent insertion, e.g. Percutaneous transluminal angioplasty, PTA, with stent insertion, for example, isolated lesion. Endarterectomy, for example, carotid artery. Thrombolytic therapy, acute emboli/arterial graft occlusion. Arterial bypass, vascular, grafting, for example, femoral popliteal graft using saphenous vein. Followed by anticoagulation/antiplatelets. Amputation, in presence of gangrene, femoropopliteal bypass, fempop bypass, for peripheral arterial disease. Venous disorders, acute venous disorders, superficial thrombophlebitis, thrombophlebitis/deep vein thrombosis, DVT/P, chronic venous disorders, varicose veins, chronic venous insufficiency, venous thromboembolism, deep vein thrombosis, pulmonary embolism, venous thromboembolism, deep venous thrombosis, blood clot in the proximal veins of the leg, less commonly in the arms. Symptoms include pain, never massage, swelling, calf circumference, redness, warmth. P could be first manifestation. Above affecting one limb, unilateral. Most common in lower extremities. 50% may be asymptomatic. Unilateral swelling distal to the site. Elevated venous pressure from venous pooling pushes fluid into interstitial spaces creating edema. May need to measure circumference. Pain on dorsiflexion, Homan's sign, is present in less than 1/3 and is no longer considered a valid sign for DVT. Tenderness to palpation of calf, never massage. Redness or warmth of the leg. Dilated, prominent, veins. Low-grade fever. Unfortunately, pulmonary embolism may be the first clinical manifestation for some. Venous thromboembolism. Pulmonary embolism. Blood clot, from DVT, breaks off. Travels to lung. Can lead to infarct. Symptoms. Chest pain. Shortness of breath. Lightheadedness, low BP. Syncope. Hemoptysis. Can be life-threatening. Pulmonary embolism untreated P. Treated P. Mortality rate of 30%. 1. Most die within hours of diagnosis. Treated P. Prospective NEJM study looked at 399 patients with newly diagnosed P. 94% received conventional treatment. Only 2.5%, 10 patients, died of P. Treatment of P is life-saving. Venous thromboembolism. Incidence estimated at 1 to 2 in 1,000. Known predisposing conditions: varicose triad, venous stasis. Alterations affect the balance between bleeding and clotting. Hypercoagulability, vessel wall injury, venous stasis, immobility or absence of calf muscle pump, paralysis, stroke, anesthesia, immobility due to bed rest, prolonged travel, obesity, pregnancy, restrictive clothing, reduced blood flow, CHF, shock, vasodilation. Hypercoagulability, abrupt withdrawal from anticoagulants, accompanies some malignant neoplasms, especially visceral and ovarian tumors, dehydration, blood dyscrasias, for example, polycythemia vera, sepsis, use of oral contraceptives, especially in combination with smoking, HRT. Vessel wall injury, physical/traumatic or chemical irritation to the vein, for example, 4 insertions/4 medications and solutions, fractures and dislocations, for example, hip, severe blows to an area, diseases of the vein, abdominal, pelvic, hip, or knee surgery. Venous thromboembolism. Risk factors: recent surgery, or colon 25, 10 to 50. Immobility. Trauma. Hormones, OCPS, HRT. Pregnancy. Previous DVT/P. Family history. Cancer. Be aware of a perfect storm. Thromboprophylaxis is effective, and every inpatient should be risk stratified. This includes nurses asking the questions, previous DVT, must identify high-risk situations and initiate prophylaxis, for example, LMWH. Thrombus formation is usually attributed to 2 or more factors of varicose triad, venous stasis, hypercoagulability, injury to the venous wall. Superficial thrombophlebitis. Clot formation obstructing venous flow in the superficial veins. May be iatrogenic, for catheters or the installation of caustic chemicals, potent drugs like antibiotics, contrast media, TPN. Best to prevent, for example, central line usage. Revisit the standard nursing care for a client receiving 4 therapy. What do you do? Iatrogenic, caused by medical treatment. Remove 4, elevate hand, warm, moist heat, NSAIDs, sometimes anticoagulants. Medical management. Anticoagulation, prevent clot formation or clot extension. Unfractionated heparin 4, continuous drip or intermittent infusion, or SC. Low molecular weight heparin, LMWH. Warfarin, Coumadin. Thrombolytic therapy. Treatment of DVT/P. Goals of treatment, short-term. Prevent the extension of thrombus and embolization of DVT. Reduce mortality for P by reducing recurrent events. Relief of symptoms. Long-term. Prevent recurrent events. Treatment of VTE. General principles. Parenteral heparin for minimum 5 days. Initiate oral anticoagulants, EA. Warfarin, on day 1. May stop heparin once INR greater than 2.0 for 24 to 48 hours. Consider outpatient therapy. No comorbidities requiring hospitalization. No hypoxia or chest pain. Need careful follow-up. Heparin, unfractionated. Heparin versus LMWH. Heparin, unfractionated. LMWH. Needs for admin. Needs up testing using nomogram. Inexpensive. Useful. High risk for bleeding or requiring surgery. Renal failure. Antidote, protamine sulfate. Square, once daily or bid. No need for routine monitoring, predictable pharmacokinetics. More expensive. Useful. Outpatient therapy. Poor venous access, unfractionated heparin. Anticoagulation effect achieved by preventing the activation of clotting factor IX and by inhibiting the action of thrombin in forming fibrin threads, drug of choice in thromboembolic disease, 4-hour half-life and, in the event of bleeding, is stopped immediately. Contraindicated in bleeding disorders or in disorders that increase the risk of bleeding, for example, severe hypertension, recent neurosurgery, active GI ulcer, cerebrovascular hemorrhage, and overt bleeding from the GI, GU, or respiratory tract. Stopped once warfarin is therapeutic, dose based on weight, considered therapeutic when the UPT is 1.5 to 2.5 times the control, normal, for pump required for continuous infusion. Nomogram used for dose adjustment, as well as frequency of blood work, based on coagulation parameters, for example, APT. LMWH. Introduced in the 1980s. Produced by chemically changing unfractionated heparin. Results in smaller molecules. Different properties than heparin. Clotting cascade, very simplified, don't memorize, keep learning it. APT. Heparin. PT/INR. Warfarin. The coagulation cascade has two pathways which lead to fibrin formation. These are the contact activation pathway, also known as the intrinsic pathway, and the tissue factor pathway, also known as the extrinsic pathway. It was previously thought that the coagulation cascade consisted of two pathways of equal importance joined to a common pathway. It is now known that the primary pathway for the initiation of blood coagulation is the tissue factor pathway. The APT, activated partial thromboplastin time, APTT, in contrast to the PT, measures the activity of the intrinsic and common pathways of coagulation. The division of the clotting cascade into the intrinsic, extrinsic and common pathways. The prothrombin time, PT, and its derived measures of prothrombin ratio, PR, and international normalized ratio, INR, are measures of the extrinsic pathway of coagulation. INR, the result, in seconds, for a prothrombin time performed on a normal individual will vary according to the type of analytical system employed. INR equals, patient PT/mean normal PTIC. International Sensitivity Index, ISI. Low molecular weight heparin, LMWH. Pros. Cons. More predictable anticoagulant response. Do not require lab monitoring. Long half-life, 4 to 6 hours, once daily or bed admin. Lower affinity for platelet factor 4, so less hit. Less bleeding complications. Can be done at home. More expensive. Patients may not like injections. Pharmacokinetics unclear is not known in certain patients, i.e. pregnancy, obesity, renal impairment. Can't reverse it with antidote, protamine. Warfarin therapy. Start with 5 to 10 mg dose, lower dose in frail or elderly patients initially. Check INRQ 1 to 2 days during initial week. Once heparin stopped, check in 2-3 times per week initially and aim to keep 2 Indian rupees to 3.0, this is the target. Once dose stable, INR checked once weekly to monthly. Vitamin K antidote, PO square, sometimes 4. Inhibits hepatic synthesis of vitamin K-dependent clotting factors. Therapeutic effect delayed for 3 to 5 days, long half-life, therefore narrow therapeutic index, therefore administered in conjunction with heparin until desired anticoagulant effect achieved. Therapeutic effect determined by the PT, desired value of 1.5 to 2 times normal, and international normalization ratio, INR, desired is between 2 and 3. Duration of warfarin therapy. Reversible cause 3 months. Idiopathic. First episode minimum 6 months. Second episode, long-term patient and family teaching. What do tell your patients so they will understand? What education would they need to prevent complications? New anticoagulants, i.e. direct thrombin inhibitors. Warfarin, oral blood thinner, for DVT/P, goal is to prevent new clots and to prevent enlargement of existing clot, does not break down clot, but allows for body to break down clot itself. Takes about 5 days to work, needs monitoring, INR, initially frequently, every 2 days, but as levels stabilize can be less frequent, needs overlap with heparin initially. Major side effect is bleeding, no contact sports, no mountain biking, use helmets, if head injury, see doctor immediately, tell doctor if procedure or surgery planned, do not take ASA, NSAIDs, etc. Do not use in pregnancy, use birth control, teratogenic, can be affected by other meds, antibiotics, can be affected by diet, keep diet stable, no excess in greens, no need to avoid completely, but don't increase consumption dramatically. Other treatments: IVC filters. Placed IVC, prevent large emboli, used if contraindications to blood thinners. Complications. Thrombolytic therapy. Lysis of clot, considered if risk of limb loss. Thrombectomy. Using catheters or surgery, used in severe cases if thrombolysis is unsuccessful, must follow strict protocol. IVC, bleeding, venous thrombosis at insertion site, filter migration or misplacement, perforation of IVC, IVC obstruction due to filter thrombosis. Nursing management of DVT. Promote venous return. Elevation of the affected extremity when on bed rest, early ambulation as tolerated, elastic compression stockings applied before ambulating, calf pumping exercises. Ongoing assessment of pain, peripheral pulses, skin color/temperature, and edema, measure calf circumference daily. Relieve discomfort. Warm moist packs, mild analgesic, monitor for and manage the complications of anticoagulant therapy. Monitor UPT, PT, INR, platelet count, risk of heparin-induced thrombocytopenia, HGB, PCV, HCT, monitor for signs of bleeding anywhere in the body, institute safety precautions. Monitor for drug, for example, ASA, drug food, for example, foods high in VTK, drug natural/herbal product, for example, ginseng, interactions that potentiate or decrease the effects of oral anticoagulants. Varicose veins. Permanently distended superficial veins due to loss of valvular competence. Common sites: greater and lesser saphenous veins in the leg, perforator veins in the ankle and lower trunk. Faulty valves elevate venous pressure, causing distension and tortuosity. Primary varicose veins, without involvement of the deep veins, often result from a familial or congenital predisposition that leads to loss of elasticity of the vein wall. Secondary varicosities, involving the deep veins, often occur due to trauma, obstruction, DVT, or inflammation causing damage to the valves as well as pregnancy. More common in women and may also be more common in those whose occupation requires prolonged standing, for example, nurses. Symptoms may include a mild aching, a feeling of heaviness, muscle fatigue, itchiness, swelling, muscle cramps, especially at night. May also show signs of chronic venous insufficiency, such as edema, pain, pigmentation, and ulceration, with increasing risk for injury and infection. Management: prevention: avoid activities that cause venous stasis. Restrictive clothing, crossing legs, sitting/standing for long periods, pressure on popliteal area. Frequently change position. Leg elevation when tired. Calf pumping exercises/walking. Elastic compression stockings, may be knee-high or thigh-high. Weight reduction if overweight. Surgical management: sclerotherapy, I.E. hypotonic saline injected. Vein ligation and stripping. Warning, especially at the end. http://www.youtube.com/watch V equals Jiang VVNJS. Chronic venous insufficiency, also known as post-phlebitic syndrome, follows most severe cases of DVT within 5 to 10 years. 50% develop chronic induration and stasis dermatitis. 20% suffer from venous stasis ulcers, marked by chronically swollen limbs, thick, coarse, brownish skin around the gaiter area, venous stasis ulceration, and itchy, scaly skin. Management. Institute measures to increase venous return and decrease venous pressure. See interventions for prevention of varicose veins. Compression stocking. Careful skin care. Avoid injury. Venous stasis ulcers reflects the end stage of chronic venous insufficiency, whereby prolonged venous pressure prevents nutrient blood flow, depriving cells of needed oxygen, glucose, and other substances, and therefore breakdown in the form of ulcers. Appear as superficial, with a beefy red to yellow fibrinous granulation tissue, with irregular borders, often exudative, located in the area of the medial or lateral malleolus/anterior tibial area and accompanied by moderate to severe edema. Another example,